Hi, you guys. How is life? How are you feeling today, my friends? Hello, Rocky. Hello, Pam. Hi, Boria. Hello, Alicia from Charlotte, North Carolina. Hi, Laura. Hi, Pam. Pam says my back is hurting bad. Could that be from IC? I haven't had a flare in ages. Is it? Yeah. It depends on where in your back, right? I mean, if it's low back, then maybe we could say your pelvic floor is getting tight. Maybe your psoas muscles are getting tight. Or if it's really sharp, intense pain in your lower back, maybe we'd be looking at kidneys, right? Maybe this could be kidney pain. Hello, YouTube. Nice to see you guys. So I am simulcasting live right now on Facebook and YouTube, and we are doing this for two reasons right now. You will notice I'm not exactly dressed up because we're actually testing our internet line, and on Facebook and YouTube, I need you guys to really do me a big favor. And if it freezes at all, if you have any hesitation, any pixelation, any fuzziness in the stream, would you immediately tell me so that I can tell them, because they're supposed to be here at 3 o'clock, but they sent me a text saying they thought they fixed it. I don't believe that yet. So anyway, let me introduce myself. Jill Osborne, president and founder of the Interstitial Cystitis Network. Yes, I should be answering that phone. This is a normal workday for me. However, life is dynamic and it's happening. I'm the National IC Support Group Leader. I have been a support group leader for 28 years. I bring you 3 college degrees, a degree in chemistry, a degree in drug development, pharmacology with a 1-year surgical internship. That means, yes, I have done surgery. And a master's degree in psychology. And my website, IC Network, was my doctoral dissertation proposal for how to deliver support to people who were homebound. And that was 28 years ago. And I'm very proud that 28 years later, my little doctoral dissertation proposal that we never got finished because I was in too much pain to drive to school because my IC back then was really quite bad. It's still rated #1 in the world by Harvard Medical School and the University of London. And in fact, do I have it right here? I'm very also proud to say that I'm now published by Harvard Medical School or Harvard, Massachusetts General. We have a brand new book called Facing Pelvic Pain that has been released. And the reason why this book is God, we could have used this 20 years ago. And I got to tell you why. Now, listen. Now, y'all know that years ago, that everybody with IC was told they had an incurable bladder disease. We no longer believe that. IC is now considered a pelvic pain syndrome. Why? Because structures outside of the bladder are also often involved. And when you actually meet other patients, you see the wonderful diversity in this patient community. For some patients, IC begins in childhood. For others, IC begins after menopause. They have the same diagnosis, IC, but are they the same? Well, hell no, they're not. For some of you, IC began after having a baby or pelvic surgery. While for others, IC began because you injured your lower back or you fell on your tailbone. You've got the diagnosis of IC, but are you the same? Hell no, you're not. And when we look inside the bladder, that's where we also see really significant differences, because for some patients with Hunner's lesions, you got big bloody wounds in your bladder. I mean, and they're painful. They're agonizingly painful. People with Hunner's lesions, you're often down to eating 4 or 5 foods. You're not responding to therapies. And the old therapies simply aren't appropriate anyway. Elmeron's not going to do a damn thing for a Hunner's lesions. DMSO is not going to do a damn thing for a Hunner's lesions. What's going to work for a Hunner's lesion is lesion-specific therapy, injecting it with a steroid. Why? Because when you look inside a lesion and you biopsy it, you see massive inflammation. So lesions require lesion-specific therapy. And now everybody around the world, all the top researchers around the world now believe that Hunner's lesions is its own unique disease. And so a lot of really, really good things have happened. But here's the deal. A lot of you watching aren't getting better on bladder therapies. You're not. You might be doing diet. That might be helping a little bit. You might have been on Elmeron for 20 years and now you have retinal disease. But if you're not improving, and even more importantly, if your bladder looks normal, then maybe we have to look outside of the bladder. maybe we've got to look for other things instead. Because in many cases, the bladder is a secondary victim to something else happening in the pelvis. And that, my friends, is where this book shines. And it's free. On Kindle Unlimited, it's free. So, and it's written by, the two key doctors, um, are Harvard clinicians, a urologist, and then a psychologist. But this has the best gastroenterologists. It's got the best orthopedic surgeons. It's got the best rheumatologists. It's got the best muscle people. It's got the best, you name it, it's got it. This is a fantastic book that will help you be a detective to try to figure out why you're having pelvic pain and or bladder symptoms. And I was very, very honored when they asked me to write the chapter on where to get support. And so, as an example, we had something really interesting happen a couple of weeks ago in our support group meeting. We had a patient come in who has something called a urethral caruncle. You ever heard of that? Caruncle, Caruncle. So what the hell's a caruncle? Her urethra was in agony. It's a mini prolapse of the urethra. Who knew, right? So if you look at your urethra and there's a little bag of tissue hanging out of your urethra, that might be a caruncle. And that has to be treated in a very, very specific way. So this has, let's see, I want to give you an idea of what the chapters are, because if you're not getting better, for God's sake, don't give up. Let's make sure we didn't miss something. And so it talks about what gynecological conditions can lead to pelvic pain, fibromyalgia. I'm sorry, fibroids, not fibromyalgia. Fibroid tumors, endometriosis, pelvic congestion syndrome, and the like. What male urological conditions can lead to pelvic pain, things with the prostate, etc. We had a very, very interesting study that came out last year that showed that 70% of the men who had chronic testicle pain, 70% had an underlying hip problem. And they needed a referral to an orthopedic surgeon to address their hip problem. What GI problems can lead to pelvic pain, what musculoskeletal problems can be involved, what bone and ligament problems can be involved with this, what neurological problems can be involved, what rheumatological, neuroinflammatory, vascular, i.e. pelvic congestion syndrome, pelvic venous disorders. And then it has chapters on how do physical therapy, diet, and exercise potentially help. Goes extensively into medications, minimally invasive interventions that can treat nerve pain, when to do surgery, when not to do surgery, how is pain different in children and adolescents versus adults, et cetera, et cetera. It talks about coping. It talks about intimacy. It talks about how to deal with family members who are messing with you. And then the last chapter, last but not least, is my chapter on how can I learn more about pelvic pain and where can I get support. And so there you go. My friends, it's free on Kindle Unlimited. If you're not getting better, if you're getting worse, or you've always had a hunch that something else is going on, or when you go back in time and you think about when your symptoms began and there was a specific incident, like falling or whatever, or being abused, or being under chronic stress, chronic tension or stress. My friends, this is the book to get. My God, it's fantastic. And so please avail yourself of this fantastic resource. Facing Pelvic Pain by Elise Day and Theodore Stern, and all these wonderful leading experts right there. They have a website, facingpelvicpain.org. You can go over there. And there are, for example, one of the things in this book that's just so good. I want to see if I can hold it up for you. Is this brand new let's see, how do I want to say it? How do they call it? They call it a treatment map. And man, if you fill this out before your appointments, right? And you can download this for free on their website, facingpelvicpain.org. This will summarize everything you need that doctor to know in a very, very quick way. But more importantly, it will allow you also to see the diversity of treatment out here and stuff like that. I mean, it shows tests, it shows related conditions. It's so good. It's good. So again, it's free. It's absolutely free. Now, on Kindle Unlimited, if you want to buy the paper version, you can also get that on Amazon. All right. So again, I need your guys' help on YouTube and on Facebook because this is a test also of our internet. Would you please tell me if you see any freezes, anything? Okay. Hi, Debbie. Hi, Beryl. Hi, Carolyn. Hi, Rocky. Angie just bought the book, getting ready to start chapter 3. On March 26th, I have an appointment at the Chronic Pelvic Pain Clinic in Indianapolis. Awesome, girl. Awesome. Patty. Patty says, I need to get checked out. Jamie, oh my God, Jamie, honey, I'm so sorry. Jamie was just diagnosed with COVID and my IC is the worst it has ever been. Have you seen this? Yes. We are doing the only IC COVID study over on our website. And what I can tell you, we have about over 100 patients now in that study. 75% report that their IC symptoms get worse during COVID. 25% report that their IC symptoms can become quite severe. And so the fact that you're flailing with your COVID comes as no surprise. You're not alone, my friend. Got to write it out. Sue is seeing your IC specialist tomorrow after a 3-month wait. Awesome. Yeah, I had my teeth cleaned yesterday. I was so happy to walk out without any cavities. Oh my God. We need success stories. Sue says, I've had a hip replacement, endo, all kinds of gastric problems. Are you doomed? No. Girl, listen. The one thing you gotta understand is that human body is wired to heal. That never stops. Healing is always happening. The challenge is that we often get in the way of healing. We get in the way of healing. And your job here is to create an environment that will support healing. And so you're gonna have to follow your hip issues. You're gonna have to follow whatever they're having you do with your endo. But even more importantly, you've got to protect your bowel, protect your bladder, et cetera, et cetera. Eat a good, fresh, healthy diet. Eat plenty of fiber, preferably soluble fiber, et cetera, et cetera. Sue says that her IC got exponentially worse with COVID. Yeah. Angie says, and my muscle pain has moved to the top of my butt muscles, just left dry needling, and oh my gosh, that hurt. She said, I found something wrong for those to be that tight, standing a different way or sitting wrong. You just got a new car. And she said it might be my car seat. Yeah, it's possible. It's possible. Hi, Sherry from the Big D. Hello, Betty. Okay, so Betty says on Facebook just now, the hand jumped across, your screen jumped twice. Okay, keep that up. Rocky says, are there any studies with, I don't know what that is, hon. You got it, your typo demon or your spell checker change, whatever that is. I don't know what that is. I don't know what that is. Deborah says, I just joined the discussion. Is Elmeron off the market? No, but I do have an update. I do have an update that I literally just got from the attorneys that we have worked with. And let me read this to you. I'm finding this absolutely shocking. So this is from the law firm Kruger and Dickinson. And if you go to elmeronlawsuits.com or .org, that is the website. That is a big consortium of attorneys that are working on behalf of IC patients. And they have attorneys on the East Coast and the West Coast and in the center of the USA. Georgia says, does desert harvest aloe cause constipation? Normally, the adverse event for aloe is diarrhea. So I don't know. The only way you'll know, Georgia, is if you stop it and see if that gets better. All right, so let me read this Elmeron update. I think it's important. According to the FDA Adverse Events Reporting System, there have been a total of 2,539 adverse events related to Elmeron use from 1997 to present. Of those adverse events reported, 1,665 have been classified as serious, and I'm shocked, 27 deaths have been reported. In 2020 alone, there were 272 adverse events reported by consumers and healthcare professionals reporting eye disorders related to Elmeron use. Reports included the following: macular degeneration, retinal pigmentation, retinal dystrophy, maculopathy, dry age-related macular degeneration, retinal toxicity, chororetinopathy, myopia, eye pain, and blindness. If you've been diagnosed with any of the following eye injuries above and wish to pursue a legal claim against Janssen Pharmaceuticals related to your Elmeron use, please be aware that the passage of time may at some point in time bar you from doing so. This is known as the statute of limitations, which is the maximum amount of time that parties in a dispute have to initiate legal proceedings. This varies from state to state. Therefore, if you decide to contact a law firm about this matter, it is recommended that you do this as soon as practicable. If you are experiencing vision issues related to your Elmeron use, our firms Kruger Dickinson and Wexler Wallace are pursuing cases on behalf of people who are long-term users of Elmeron who have suffered visual injuries, including pigmentary maculopathy, macular degeneration, and damage to the macula. And then they have a Elmeron website, elmeronlawsuits.org. So it's elmeronlawsuits.org, or you can call them toll free at 888-823-3222. And they say they'd be happy to discuss your case with you. So what I found shocking about this is that there were 27 fatalities reported directly related to Elmeron use. I have never seen that before, and they gave the link for that. And so let's take a look at that really quickly. Hold on, it is loading. Opening the sheet. Hold on. So you know what I'll do is I'll actually post this link to Facebook and YouTube so you guys can do this too. So hold on a sec. It just worked for me. All right, hold on a sec. Oh, it's on the wrong computer. Oh man, oh God, there you go. I'm thinking I can copy from another computer, paste onto this computer. How silly am I? Hold on, I just got to open this. Let me open this on this computer. Let us see here. All right, it is opening. All right, so let me give you this link, and this is to the federal database where you can search for Elmeron adverse events. All right, so Facebook, did you get that? There you go. All right, so Facebook, you have the link there. YouTube, let me give you the link here. But you guys on YouTube are very quiet today. This is a drop-in meeting. All right, YouTube, there you go. You have the information now. So I am opening this up on this computer. I might have to open it in a different browser. Let's see. Hold on. Wow. All right, here it is. 1,665 serious cases, including deaths. The FDA has 27 fatality reports associated with Elmeron. 387 adverse events filed last year, 174 the year before. I'm going to give us details. Well, you got to kind of massage it to get the details. Oh, look at that. 376 in 2015, 272 in 1998, the year after it was approved. Wow, there's a lot of adverse events in here. I've always associated Elmeron. What we know with Elmeron, I mean, the more common side effects with Elmeron are going to be your hair falling out, liver enzyme level changes, um, um, maybe blood thinning. If you were on Elmeron and you were scheduled for surgery, they would normally have you stop using the Elmeron. Hi, Barbara. How are you? Penny says, should everyone with IC be on disability? Absolutely not. No, absolutely not. Most people with quote unquote IC, now remember we do subtyping now, do not need to be on disability. It depends upon what the underlying anatomical issue is. So if you, for example, let me give you an example of something that I would consider to be quite disabling, would be number one, extreme Hunner's lesions. Hunner's lesions so intense that your bladder capacity has fallen. That would be an example of something that would be pretty disabling. If you can't sleep through the night, if you're getting up every 20 minutes, if you can't sit in a car for a long period of time, if you can't make long drives without being in pain, those would be factors that would play a role in you getting disability. But you've got to remember there are three different types of disability. Number one, there's private disability. Does your employer offer a private disability insurance plan? Secondly, there's state disability. State disability is normally a one-year program. The purpose of state disability is to get you through a short-term disability, like if you've had a baby, if you have to have a hip replacement, if you've had surgery, been injured, and you need a couple months off. That's when state disability kicks in, but you can only get it if you've paid into it through your health insurance, through your paycheck. So state disability is an insurance program that is paid for through your paycheck. If you've never paid into it, you're not going to be eligible for it. And that's one of the reasons why I always tell people, and this is particularly true for Social Security, even if you only make $5,000 a year on part-time job, 5 hours a week, 10 hours a week, it's important to make sure on that paycheck that they are taking Social Security wages out of it and SDI wages out of it, because then you will be potentially vested, right? So you got state disability. I got state disability for a year. I praise God, hallelujah, I got that. Not a lot of money, but I think I got, this was 28 years ago, like $500 a month. I don't know, it wasn't a lot. But the other cool thing about state disability is that you can go back to work, and so if you can go back part-time, you just report you report your income, and then they reduce your disability. But the purpose again of state disability is to get you back to work. They want you to work. And frankly, I wanted to work. I didn't want to be out on disability. I wanted to work. And I do work now, and I have worked steadily for the last 25 years. But when IC's intense and the pain is really bad and you don't know what the hell's going on and you can't sleep at night and you're up every 20 minutes and you're exhausted physically, mentally, and emotionally, and you can't perform the essential functions of your job, very hard if you're sleep deprived, or if you need medication to control pain that would interfere with your job, then that's good context for applying for state disability. Federal disability is a whole nother situation. In the federal program, administered through the Social Security Administration. And I know this because that was my first job after I got out of grad school because I didn't want to do pharmacology. I was a black lung specialist in California where we didn't have black lung. It was ridiculous. I ended up doing overpayment investigations instead. Okay, so anyway, um, uh, there are two fundamental programs that Social Security administers. The first one is SSI, Supplemental Security Income. Supplemental Security Income is for people who basically have never worked and who have profound disability. And so this SSI was really created for people who were born blind or people who were born with major birth defects. But it also applies to people with severe disability. And so to get SSI, you don't have a work history, and you do go through a fairly moderate review of your case. So you can call the Social Security Administration or go to ssa.gov and learn a little bit more about the SSI program. So if you, for example, never worked or you only worked a couple years, then that's going to be your only option because Social Security Disability Insurance, SSDI, requires that you have worked and paid into the system. You are required to work 40 quarters to be vested for Social Security retirement and or Social Security disability. And Medicare becomes part of that, right? So how do you earn a quarter? You get 4 quarters a year. So as long as you have a paycheck, even if it's a tiny paycheck, let's just say you make $1,000 in 3 years, but that's reported. There's an income limit. I don't know what the actual current income limit is. It might be 2,500. I don't know. You have to go to their website, figure it out. But it's really, really important that when you do work part-time, don't work under the table. Do it officially to make sure you get vested, to make sure you earn your quarters. That's vitally important. And so after my IC, well, I was vested by the time my IC started because I was already working. I wasn't making a lot of money because I was working for the feds at the time. And then I also had part-time jobs at bookstores and Christmas jobs and things like that. But it's always in your best interest to make sure that you get Social Security on your paycheck. The other thing about Social Security benefits, disability benefits, is that you can't wait too long. So let's say you work 20 years, but you haven't worked the last 10 years because you're thinking, you know what, no sweat, my husband's supporting me or my partner's supporting me. And then you get divorced. And you've got an extreme disability and you can't work and you haven't worked for 10 years, but man, you were absolutely vested. Guess what? If you don't apply within a specific period of time, you might not be eligible for disability benefits. You would be eligible for retirement, but not for disability benefits. And so you also can't sit on it. You can't sit on it so remember, state disability is about getting you back to work. Federal disability is about assuming that you will never be able to work. So the purpose of the federal disability is to step in and provide you long-term support. So if you're at home and you're just like your IC's pretty moderate, it's limiting your ability to work, but you have worked in the past, don't wait. Don't wait because you could wait too long and fail the time test. All right. Now, with the Social Security disability process, since that was the area that I worked in briefly for a year before I went back to grad school, understand that they deny everybody, like 95% of people get an automatic denial on their application. It's pro forma, it's not personal. What they're really trying to do is to figure out who's determined. And they're not going to say that publicly, but privately, it's kind of a test. Do you really need it? Because if you really need it, you will file for a reconsideration. So the one mistake the patients make is you get a file, then you get denied. You get the denial letter and you go, well, that's done. And you walk away. Don't walk away. That's exactly what they want. They want you to walk away. Instead, what you do is you follow the next, you've got 30 days or 60 days to file a reconsideration. Do that, because that's when people start getting approved. You can go to the reconsideration, then you can go to administrative law judge, et cetera, et cetera. I have a whole section on our website that talks about Social Security. And, some IC patients absolutely get it. You absolutely deserve it. Others, you might apply for it and you might not meet their criteria. And I would be happy to talk to you about that at some point in time. Deborah says, has IC been known to disappear? So, Deborah, this is where the word IC is so vague. It's too vague. So we have subtypes now. So question number one is, have the Hunter's lesions been known to disappear? Absolutely, they do. They do. Can chemo-induced bladder irritation, IC subtype 2 bladder wall driven disappear? Yeah, because the bladder can heal. Can estrogen atrophy suddenly disappear? No, it's not going to disappear. We are getting older. And yes, we can make it a little bit better with using some estrogen. But, if you are of a certain age and your skin is starting to get dry and you've got genitourinary syndrome of menopause, as every woman goes through, that's not going to suddenly disappear. What you've got to do is make sure that you're perhaps using a little bit of topical estrogen to help those tissues to produce mucus, which your bladder needs to protect itself. Can pelvic floor dysfunction disappear? Absolutely. Patients are cured. If you are IC subtype 3 pelvic floor driven and your bladder wall is completely healthy and they've discovered that you have an underlying muscle issue, that is absolutely curable. And that's what Chris Payne said when he proposed his subtypes. He said it was a shame. It's a tragedy that so many of you are told that IC is incurable. It's wrong. It depends upon your subtype. So if you've got a pelvic floor injury, muscles respond beautifully to muscle therapy. If you have IC subtype 4 pudendal neuralgia, that's a little bit harder because now we got nerves that are involved. We're going to have to calm those nerves down and relax the muscles. And if you've got IC subtype 5 central sensitization, chronic overlapping pain conditions, can that disappear? Central sensitization can calm down as nerves are calmed down and as we retrain the brain, because IC subtype 5 central sensitization is really a central nervous system processing disorder. Okay, Betty says, when I do core strengthening exercises and squeeze my butt, I get bladder spasms during the night. You have difficulty emptying your bladder and you've got vulvodynia pain. When I had pelvic floor physical therapy, I got to the point where I had to halfway stand up and wait 10 minutes before I could urinate. So what's your advice? Well, so number one, I'm not a doctor. I can't give you medical advice. My job here is to educate you, inform, kick you in the butt, get you back to your doctor with better questions. And that's what I have got to do with you, Betty. I think you've got to go back to the doctor or back to the physical therapist. And it's time to get kind of deep into your muscle dysfunction. It sounds like you have an underlying glute piriformis muscle problem. And, your glute muscles and your piriformis muscles, everything is connected down there. They will all influence each other. And so, I think if I were in your shoes, I would be going back to them and saying, listen, why can't I urinate right away? Why do I have to stand for 10 minutes? They might be giving you the wrong exercise. They might be telling you to do it too long, or the exercises you're doing are exacerbating something else that's going on. One of the reasons sometimes why patients have piriformis syndrome is because they have an SI joint issue, they've got a bony structure hip issue, an orthopedic issue. So, um, I think you need to ask them how and why that could happen. And the other thing I want to know, so, where's this book? Hold on a sec. Speaking of books, Betty, you need this book. This is called Breaking Through Chronic Pelvic Pain, a holistic approach for relief. And it's free on Kindle Unlimited, my friends. Come on, no excuses. You avail yourself of these fabulous resources here. And so this is a masterclass in muscles and nerves and bones and the pelvis and your bladder and all that sort of stuff. It explains where everything is. It explains how things influence each other. It's stunningly good. And I would, if I were you, dive into this before you go to your next physical therapy appointment so that you can talk about with the muscle groups. So you know where each muscle is. That's important. The fact that you have vulvodynia pain after when your muscles go into tension, completely normal. He talks about that in this book. The fact that you have urinary retention makes sense because if your muscles are tight, it's going to be hard to relax enough to empty your bladder. Okay. So, Betty, please avail yourself of this book. Read the chapter on vulvodynia, or read the section on vulvodynia. Read the section on the muscles, and I want you, as you're reading it, to be thinking about and your history here. Do you remember any injuries? Do you remember any falls? Is there anything else that might be going on? I mean, clearly you have a big time muscle issue going on. That's not bladder, that's muscle all the way. Sylviane says, I have eye damage caused from Elmeron. My specialist is 100% sure that's what it is. I'm the first case he has seen. So scary. My eyesight is going down so quickly. Yeah, Sylviane, unfortunately, that's what the research shows. The research is absolutely showing that the damage can progress even after you stop the medication. So it's very important that you stop the medication. You definitely want to maybe learn about the lawsuits a little bit more because you want to be involved potentially in one of these class action cases. So go to elmeronlawsuits.org and you can learn more about that. Lynn says, I just froze 12 minutes ago. Good. Guys, keep telling me on Facebook if I'm freezing. Patricia says, hello from Montreal. Hello, Canada. Hello, Montreal. Pam says SDI is a California program. If you're in another state, they might not have a similar program. Most of the state, you're right, Pam, but most of the states do have a state disability program. It might not be called state disability, SDI, but you've got to maybe look at your government listings, go to your state website and put in disability insurance and see what comes up. Pam says, I was able to get federal disability on the first application. I have pulmonary hypertension and I'm on oxygen 24 hours a day. I'm glad you got it, hon. Mary says, is prune juice bad for IC? It depends upon if they put ascorbic acid in it. Prune juice works not from a fiber standpoint, but because it's a bit of a spasmodic. And so what happens is it makes your bowel kind of start moving things along. It moves things along more. And so if you're prone to bowel spasms, then prune juice and senna would potentially make those worse because they trigger more spasms. My mom raves about prune activia, though. She loves it. Patty says, glad to catch you this afternoon. Hope everyone is staying warm. It's chilly up here in Upper Michigan. It was really cold last night here. That's for sure. All right, so Facebook, let's you know what I want to do here? Oh, God, I have a product reveal. Hold on. Look at this. This is I forgot to do this on our Sunday meeting, but it's now up in our store. Look at this. We finally have it. My Daily D-Manos. So, I don't want you to be confused about this. There are a lot of people who are saying that IC is chronic bacterial infection, and they are wrong. They are wrong. If you actually spend time with patients, you quickly see the diversity in this patient community. And so I certainly am not going to support anybody suggesting that every single IC patient has chronic infection. That's ridiculous. Absolutely ridiculous. But here's what we do know. We do know that patients with Hunner's lesions may have a viral infection in their bladder wall. We have research from Europe, and now we have our own National Institute to Health MAP Research Network viral study. They took them 4 to 5 years to do it. It was released last year, which showed that a small percentage of IC patients actually had active viral infections in their bladder wall called polyoma viruses. A polyoma virus is a virus we all have. It's part of the normal virome of the human body. It's not a sexually transmitted disease. Do not freak out about that. It's something that we all have. But normally it's silent. But in some people, it gets turned on, usually because of an autoimmune disorder. Or if you're on anti-rejection drugs, like if you've had a kidney transplant, you got to take anti-rejection drugs that suppresses the immune system. And that creates an environment for the polyoma virus to turn on, right? So we now know, again, confirmed by our own National Institutes of Health, that a small percentage of patients have viral infections, under 10%. And of course, the challenge here is that when you have all the symptoms of infection, frequency, urgency, pressure, pain, man, you are bawling your eyes out in pain. Please, doctor, help me. It hurts so bad. And they do a urinalysis and it comes back negative. And that's because urinalysis don't test for viruses. And even more importantly, they don't test for fungus. Because again, it was our own National Institutes of Health 5, 6, 7 years ago who discovered that many IC patients who were flaring because they had Candida in their urine. Yeast. And I was one of those people, man. I had a 2-year Candida, a drug-resistant Candida labrata infection that brought me to my knees. You want to talk pain? Holy hell, is a Candida infection painful in the bladder. And they are a beast to treat. If you look at several years ago, the Center for Disease Control released the top 10 drug-resistant pathogens that threaten humanity, right? And you had 9 bacteria and Candida because they are adapting so quickly. And most of them are now resistant to over-the-counter pain medication like Monistat. So if you flare when you eat sugar, if you flare when you eat carbs, then we really have to look at the potential of of having maybe a Candida infection in your urine, a fungal infection in your urine. If you go on over to our website, icnetwork.org, and search for Candida or search for yeast or fungus. I wrote a blog on it with all the research cited, and you can print that out and share that with your doctor because this is real. The Center for Disease Control is the one who really started this whole shebang when they put Candida on their top 10 pathogens. So it's possible. And of course, it's even more likely because so many of you have taken antibiotics. If there's ever a group of patients who are completely overexposed to antibiotics, it's the lower urinary tract patient like you and me. My God, when I was a kid in 7th grade and I first had frequency urgency, I remember having to sit in the doctor's office and swallow 16 sulfa pills. And of course, they thought it was infection. And now I know in hindsight it's a tailbone injury. I had fallen and broken the tip off my tailbone. But I had like 100 urethral dilations. They gave me antibiotics every time I had a urethral dilation back then. My diagnosis was because they weren't diagnosing IC in kids back in the 70s when this was urethral stricture. Urethral stricture. In other words, when I was trying to pee, it was like I was trying to pee through a needle. My urethra was really, really narrow. So their answer for that was to shove a metal rod up there and dilate it. And of course, as you're a kid, I mean, it doesn't matter how old you are. It's pretty awful. Penny says, does Candida make you feel like you're burning every time you urinate? Yeah, it can, especially inside the body. So the tragedy here is that they never ask the question, gee, why would the urethra be tight? Hmm. Could it be because the muscles around the urethra are tight? Could it be that the levator ani muscles have been traumatized? Oh, guess what? Yeah, Jill fell on her butt. She broke off her tailbone. I'm sure I had a levator muscle injury, and so we are massively overexposed to antibiotics. And now we've got this very vocal group of people online who are saying everybody should take long-term antibiotics. And we have something called antibiotic stewardship now. People are dying with these antibiotic resistant infections. Why does antibiotic resistance happen? Because there's too much of it being used. A lot of antibiotic resistance infections are coming from food sources. There was a very famous case about 15 years ago of a whole bunch of college students in Oregon, Washington, and Idaho all getting this really rare E. coli bladder infection. And they were able to trace it back to a slaughterhouse. And they were able to then trace it back to a farm that had used massive amounts of antibiotics in their feed animals, in their cattle. So, the rule kind of now is, I mean, can you get a bladder infection? 100% you can, no doubt about it. Especially if you're older and you have estrogen atrophy, you're going to be more prone to infection. But don't self-medicate with antibiotics. Go have the test first. And the best test of all is something called a next generation DNA urine test. So go to bladderhealth.org, bladderhealth.org. You watch a bunch of videos of doctors who use this very, very successfully to figure out what kind of infection do you have? Is it a viral infection? Is it a fungal infection? Is it a bladder infection? And most importantly, it will tell you all the resistances because it looks at the DNA and it compares the DNA that they found in your urine with this giant database at the Center for Disease Control. And they will be able to tell you what antibiotic resistance genes are present. And then they will be able to give you much better treatment recommendations. There was a study that came out like a week ago that showed that it was a study of rural as compared to urban women with UTI. And I think they said 50% of the women were given the wrong antibiotic and or were told to take it for a much longer period than they should have. So this is a very dynamic area. There's people out there who would be very angry that I'm saying don't use antibiotics, but I don't care. I'm telling you right now, get the proof first. Because here's what we do know. Fungus is happening. Candida is happening. Why? Because a lot of you are overdoing antibiotics. You're taking it just in case because y'all have that pill bottle next to your bed. You're saving it just in case, and you're forgetting that antibiotics have an anti-inflammatory effect. And that's why you might feel good after taking an antibiotic. Penny says, is treatment for Candida over the counter? Well, that's the issue. Candida is very resistant now to a lot of the over the counter medications like muscle and nerve issues in the pelvis. Melanie says, is there any connection with Ic and endometriosis? I've had Ic and IBS since I was 14. My daughter was just diagnosed with endo. The reason I'm asking, the doctor has told me I could have silent endo and not know it. I've been reading a lot about endo lately. I read a blog where a girl said she was misdiagnosed with IBS when she had endo, and you can't see it without an endoscope because it grows outside the organs. I know endo can bother the bladder and intestines and colon. Makes me curious if there's a link. Yes, Ic and endo are called the evil twins in research studies. Ic, IBS, and endometriosis are sometimes called the evil triplets. Oh, Patty, thank you for telling me about the freeze. I really appreciate that. So the question is why? Why does that happen? And there are a couple of different explanations. Number one, endometriosis itself can absolutely irritate the bladder. It can attach to your bladder. It can burrow into your bladder wall. It can go all the way through into your bladder cavity. So uncontrolled endo is really difficult. It's very, very difficult. The challenge with endometrial tissue is that as your hormones go up and down, when it's time for you to have a period, the endo that's elsewhere in your pelvis is also going to bleed. And that's why endometriosis causes such terrible pain and cramping when you have your period, because that endometrial tissue changes with hormone and it will bleed. Even if it's up in your chest, up by your waist, it's still going to bleed, and that's going to be painful. The second thing that happens with endometriosis is because it is painful, it's going to cause muscles to get tight. So the odds are you're probably going to have tight pelvic floor muscles. That's called the guarding reflex. And then the third thing that happens is that there are consequences to long-term pain on the central nervous system. And so it is the endometriosis patient who may often then start feeling bladder symptoms, and then bowel symptoms, and then vulvodynia symptoms. They start getting some of the other chronic regional pain syndromes, right? Or the chronic pain syndromes. You might end up with TMJ. You might have fibromyalgia, things like that. And that's really about kind of a central nervous system that is being challenged by pain. It's being challenged by trauma. And what we've got to do is try to get your brain out of that fight or flight pattern, because when you're in pain, it's scary. And so your brain is thinking your life is at stake and that you're facing a saber-tooth tiger, even when you have a cramp. And our goal here is we've got to calm that brain down. We've got to get that brain out of that high stress situation, because that's just going to amplify the pain. It's going to intensify the pain. Pain that is accompanied by anxiety will be intensified by the brain. Pain that is accompanied by laughter will be minimized by the brain. So Melanie, you need to join the Endometriosis Association. Google Endometriosis Association. We do now have some good clues as to why endometriosis happens. And it happens because of chemicals that have an estrogen mimicking effect. Dioxin, we now know, is strongly linked to endometriosis. Dioxin is the most poisonous chemical ever produced by man. And it happens when you burn plastic. So if you're burning plastic in your fireplace, the dioxins are being produced, they're going out of your fireplace, they're settling in the environment, right? So they're now settling in the grass. And if you've got cows and your cows are eating your grass, your cows now have dioxin. And if you're drinking the milk from those cows, you will then be exposed to dioxin. And about every year or two, we have yet another chemical that has been linked to endometriosis because it is an estrogen mimicker. Even PVC pipe, that's why your water pipes, you want to make sure your water pipes are copper and not plastic, or that plastic on the inside lid of tin cans, that plastic coating. It's a very, very big deal now. Everybody's talking about it. So when you think about the fact that during World War II, there were only 10 or 15,000 endometriosis cases in the world, and now there are millions, why? And you have to look at the corresponding increase in the use of plastics and other harsh chemicals. That's the other thing that's a great tragedy here is we are exposed on a daily basis to new chemicals in products that are imported, like from China. And so one of the things that the Endometriosis Association tells everybody, and I do that on our website too, is, man, we got to get rid of all the chemicals in our home. Man, no Febreze, no scented candles from China. No, oven cleaner. You got to remove the chemicals from your home. You can't use those old time oven cleaners. They're too aggressive. You have to use plant-based cleansers that are not as traumatic. So again, if you go to our website, there's a section on how to clean up your home. and to remove those chemicals. So please, again, Melanie, number one, don't feel guilty. You didn't do anything wrong. None of this is your fault. This is truly a man-made issue, and I don't want you carrying any shame or any blame from that. Instead, we have to look at our communities and look at toxic producers in our communities and polluters in our communities and really try to hold them accountable. I mean, God forbid you're in West Virginia where we have all the problems with coal mining and all the water toxicity that's happening there. I mean, there are consequences to letting manufacturers get away with releasing stuff into our environment. And endometriosis is a perfect example of that. Shannon says, hello, I'm new here. I have pain, feel like fire in my bladder. I'm going every 15 minutes. The doctor only prescribed oxybutynin, but it's not working. I don't know what to do. Please. All right. So Shannon, so it's important to understand that yes, it could be your bladder, but it could also be your pelvic floor muscles. And so we want to make sure, number one, you have a correct diagnostic workup. We need to know what your anatomy is. And so the assumption is you feel like you have a bad bladder infection. You've gone to the doctor says your urine is clear, and yet you're peeing every night. So that's when we start looking a little bit at the subtypes. But that peeing every 15 minutes tells me that your bladder wall is probably really, really, really irritated. And so literally one of the very first things you want to do, according to the American Urology Association, is increase your water intake. We got to dilute your urine. A lot of patients stop drinking water because you associate water with frequency, and you're letting your urine get really, really concentrated, which means it's now getting super, super irritating. So increase your water intake. Make sure you're drinking your normal 6 to 8 glasses of water a day. That's what the AUA says. The second thing we want to do is make sure that you're not giving yourself a chemical injury, right? So if you're drinking coffee, green tea, black tea, soda, artificial sugar, if you're taking a multivitamin every day, that could irritate your bladder wall. Smoking will absolutely irritate your bladder wall. And the secondhand smoke will irritate the bladder walls of anybody else in the home that's exposed to that, including children. So now we have to rule out chemical injury. And then we want to try to understand maybe why your bladder is more vulnerable. So I can't, because you don't have a picture here, I don't know how old you are. If you've had a hysterectomy, if you're on birth control, if you are perimenopausal, menopausal, or postmenopausal, that changes in estrogen level is going to change your bladder wall. Your bladder is like your mouth. It's a hollow organ covered with a really thick coating of mucus. And the purpose of that mucus is to protect it. It's a barrier. It prevents irritants in urine from reaching the fragile cells and nerves in your bladder wall. So we call it the mighty mucus. Unfortunately, that mighty mucus in your bladder and in your urethra and on your vagina and in your vagina and on your vulva are estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus, and you can get away with crap drinking sodas every day. But when you're older and you have less estrogen, or if you're on birth control, or you've had a hysterectomy, or you're on Lupron, guess what? You don't have a lot of estrogen. So what does that mean then? You don't have a lot of mucus. That's not a disease. That's estrogen atrophy due to aging or hormone changes in hormones. And so that's the next question that you want to ask your doctor. So come on over to our website, icnetwork.org, and take a look at the section on the 5 subtypes of IC, the subtypes and phenotypes. I think that might help you. And then if you sign up for our free newsletter over on our website, we have a 40-page flare management guide with hour-by-hour rescue plans. So if you're having a diet-induced flare, a bladder wall flare, we tell you what to do every hour for the first 24 hours to try to get through it. And if you're having a pelvic floor flare, we also give you a separate plan for that. So if your flare started because you had a soda, okay, then that's a bladder wall flare from acid irritation. If your flare started because you had sex, that's a muscle flare. You're going to be peeing a lot, but that's a muscle flare. Or if your flare started because you've been sitting for a long period of time or took a drive. So our therapeutic priority for the bladder wall patient, the soda patient, is to dilute the urine, calm and soothe the bladder. If it's the pelvic floor, our therapeutic priority is to relax the muscles. Shannon, something else you could try. Where is it? Oh, here it is. Here it is Azo bladder pain relief tablets, also known as pyridium. This is the over-the-counter version of pyridium. This is the stuff that turns your urine orange, but it does act to numb your bladder wall to a certain degree. And so this would be something that would be reasonable to try. And if you'd like to talk at some point in time, feel free to give us a phone call. You know, I do patient, I'm supposed to be doing patient coaching right now, but again, we're testing our line. Got another 10 minutes. We'll go till 2:30 Pacific time because the cable company is supposed to be here at 3. Figure out why this is stopping and starting. Okay, Patty says, I can attest to tight pelvic floor muscles thanks to endometriosis. Pretty much everything Jill is saying here. Mary says, does endometriosis ever go away? It calms down when you're menopausal, postmenopausal. When you stop having estrogen highs and lows, and you stop having your period, endometriosis usually feels much, much better. The problem, Mary, is if you have adhesions that are affecting other things. Normally, somebody who has endo, at least once you probably have a laparotomy where they might want to release adhesions. So it's important to know if it's attached to your bladder wall. You know, endometriosis is like knots, hard tissue that kind of wraps around things. It's really challenging. So if it's wrapped around your bladder, if it's wrapped around your bowel, if it's wrapped around muscles or nerves, that could be an issue that they might want to address surgically. Yeah, Vicky says, yeah, BPA in tin cans, yes. Melanie says, oh my God, we're huge candle people. You know, girl, get beeswax candles, unscented, that's fine. Penny says, I haven't been on any estrogen in the past 2 years. Should I be put back on some? And the answer is, if you have symptoms of genitourinary syndrome of menopause and your skin is dry, that yes, normally they would suggest a topical estrogen. Marlene on Facebook says, on YouTube says, is psyllium good to heal the bladder wall? No. Psyllium does nothing for the bladder. What psyllium is a fiber that you would take if you are struggling with constipation. Or even if you're struggling with diarrhea. They're both problems with fiber. The challenge with psyllium is it's half insoluble fiber and half soluble fiber. And that's a problem because if you've got IBS, insoluble fiber is kind of triggering. We do better with a soluble fiber, 100% soluble fiber, and that's going to be acacia fiber. Whoops, hold on a sec. And let me show you what that is. Hold on. All right. So this is Heather's tummy fiber, which you'll see is organic acacia Senegal tummy fiber. This is game changing for somebody with IBS because, you know, like I'm in IC subtype 5 central sensitization. So I had frequency urgency in 7th grade. I had vulvodynia in high school. I had polycystic ovarian syndrome in college, IBS in my first federal job, TMJ, migraines, and then IC when I was 32. And that's because I have a central nervous system processing disorder. But one of the reasons why my bowel was getting so incredibly irritated was because I wasn't eating enough fiber. My bowel movements were marbles, hard marbles. Y'all know what that is like, passing a hard marble. And then you're straining and straining, and you pop a hemorrhoid, and you pop some blood vessels, and then everything gets that much worse. And I had an extremely painful rectum. Holy moly, it was so bad. And I went and saw an IBS specialist, and literally it was the best doctor's appointment of my life. It was so good. I mean, she spent an hour with me, and we even went through childhood all sorts of interesting things that now make total sense now. But one of the things she asked me, she said, well, how many grams of fiber do you eat a day? And I looked at her and I went, I have no idea. Nobody's ever asked me that question, but I'm sure it's good. And she goes, well, I double dog dare you. Go home and count up your fiber. You need to eat 20 to 25 grams of fiber to be healthy, to have normal bowel movements. Count it up, email me, let me know what it is. And she gave me this wonderful fiber chart. So I go home, I count it up. Would you like to know how many grams of fiber I was eating a day? 6 on a good day. No wonder things were hard and uncomfortable. And when I used my fiber chart and started increasing my fiber and also use this, I usually would do like a teaspoon or a tablespoon of this and a shot of water and just chug it. And it doesn't have any flavor or anything like that. It was like miraculous. I remember like 3 days later, it was like, oh my God, it was just completely normal. Oh my God, it didn't hurt. There are a lot of things they don't tell us when we're kids. And there are a lot of things mom doesn't tell us, or we throw mom off. Mom will say, eat peas. You're like, no, I don't need to eat peas. I hate peas. Well, peas, 1 gram serving of peas is 13 grams of fiber. Literally, eating peas is good. 1 apple is 4 grams of fiber. Eat an apple a day. It's going to need to be a Gala apple or a Fuji apple to be lower in acid, though. So we got to get your fiber level up. But just please understand that psyllium will do nothing for the bladder. It's all for your bowel. And again, instead, we suggest a soluble fiber, Heather's tummy fiber, or a regular girl. Regular girl's really good. And these are both in our shop. And we have little travel kits, travel packs. You just cut the tip off, pour it in a glass of water. It's perfect. That's what I'm doing right now. In fact, I did it in here. There is fiber in my rooibos pumpkin spice tea this morning. No flavor, nothing. Amy says, yeah, I'm new here. Your information has given me lots of hope. I've been constantly feeling pain around my urethra, so that if our pressure, sitting down, putting a pillow in between my legs, I get some relief. I asked my doctor if I should try pelvic floor PT, and she told me most people see no. What? Are you kidding me? We had our first pelvic floor physical therapy national study released in 2008 that showed that pelvic floor physical therapy was stunningly effective at reducing the symptoms of IC. And when that came out, that was a multi-center study done by the National Institutes of Health. That is the moment that turned the IC world on its head, because at that time, everybody thought this was a bladder disease. But guess what? If it were a bladder disease, pelvic floor therapy wouldn't help. But the reality is that study showed us that pelvic floor physical therapy was stunningly helpful at reducing symptoms of IC. And that's when people went, uh-oh, maybe for some people, it's not the bladder. Maybe for some people, it's muscle. So absolutely, Amy, go have a pelvic floor assessment. If you have pain when sitting that is relieved by standing up, that is muscle and or nerve. You need to have a proper pelvic floor assessment. And I call bullshit on a doctor saying patients don't get help. We've got the studies to prove it. I have been tremendously helped with pelvic floor physical therapy. You know, I call it the chicken or the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? They're both involved. They cannot not both be involved because they are so incredibly interconnected. It's called the viscerosomatic reflex and the somatovisceral reflex. But one is normally driving the other. So for some of you, like the patient who just had a terrible diet and drank diet soda all day, yeah, you got a chemical injury of your bladder, and because your bladder's screaming, your muscles are going to get tight. Our therapeutic priority for you is to calm the bladder down and hope that the pelvic floor muscles release. But that's the smaller group. The bigger group are patients whose symptoms began after a fall, a car accident, having a baby, injuring your tailbone. If you were an athlete, if you were a gymnast, ice skater, cheerleader, where you did flying splits and you landed directly on your crotch on the floor. If for a man, if you were a paratrooper, football player, wrestler. Now you have no clue you have a muscle injury. Your first symptom is frequency urgency. You call the doctor and say, hey man, I think I have an appointment. I have an infection. They send you antibiotics. They don't work. You go back to the doctor and say, hey, It's still here. This infection's still really bad. Doctor gives you more antibiotics. They don't work. Then the doctor says, let's do a culture. Your culture comes back negative. You're going, oh shit, my culture is negative. Then the doctor goes, well, I think you've got overactive bladder. Let's give you diterpandetrol. They don't work. You go back to the doctor. The doctor goes, man, I hate to break it to you. I think you got IC. It's this incurable, awful bladder disease. And they tell you about Elmeron and give you the diet. And then you're on Elmeron for years and you don't get better. Bladder therapies don't work. Why? Because for that patient, our therapeutic priority is to restore blood flow. Why? Because injured muscles are tight muscles. Tight muscles restrict blood flow to the bladder. They restrict blood flow to the urethra. They restrict blood flow to the rectum. They restrict blood flow to the vulva. They damage nerves. They restrict blood flow to the nerves. And until we get that blood flow restored, that patient is always going to be struggling. So our therapeutic priority for the pelvic floor patient is to restore blood flow. How do we do that? With pelvic floor physical therapy. And we have to address any other physical orthopedic issues that might go on, because some of you have chronic muscle tension. Your muscles have been tight forever. Why? Could it be that you have one leg longer than the other? Do you have a hip injury? Do you have an SI issue like I do on my left side? Do you have a knee problem? Do you not walk normally? Or do you have a foot problem? Because for a lot of you, it goes right back to you walking. And the thing is, as Dr. Weiss talks about in this book, and Amy, you need to get this book. It will help you tremendously, and it's free on Kindle. It's $29, the print version in our store. And I would recommend the print version. It's $36 on Amazon, $29 from us. Because I don't know about you, but I read by colors and by highlighting. I mean, I learned that way. And so I needed to have something that I could highlight for me to really absorb this information. This book will be life-changing for you because it will help you understand what is hurting when you sit down. One of the things that's so cool about this book, by the way, and it talks about IC and vulvodynia and rectal problems and a new condition. I never heard the name of it before, called proctalgia fugax. How weird is that? Proctalgia fugax. You know what that is? That is episodic, random, severe rectal pain. Just like literally your rectum hurts so bad for like 4 to 5 minutes, and then it goes away. A couple days later, here it is, and then it goes away, and you're just sitting there going, "Oh my God, what do I do?" And that actually still relates to muscles and nerves. But I want you guys to look at this picture. So one of the risk factors for pelvic floor dysfunction and IC and pelvic pain is bike riding. So look, here's your pelvis, here's your hip bones, right? Here's a bike seat. Look at what the bike seat is pushing up against. Your inner bits, the most sensitive nerves and the most sensitive muscles in your pelvis have no protection. Bike rider syndrome, cyclist syndrome. And if you look at this, if you look at this model, this makes it all the more apparent. So look, here's your hips. Bam. There's your tender bits. Let's put your levator on here for a woman. Get on there. Stick. Whoops. You know, the magnets are just not working so well. Stay. So think about what the bike seat is pushing against right here. It's pushing against the muscles and the nerves embedded in these muscles. If you've got PGAD, which is, okay, what does PGAD? A persistent genital arousal disorder, where you're feeling like slightly aroused, but it's painful. That is because something is pushing against the nerve inside the levator, right? You can see how that happens. Cyclist syndrome. This happens to long-term professional bike riders. It's real. But it also happens to ballerinas. Because think about ballerina. I did ballet for about a year, right? So think about a ballerina, right? So ballerinas are taught to tuck under, just like this. And then you're walking like this. And you're dancing tucked under. But that's not the way your body is supposed to be. Your body is supposed to, your back normally arches out. It doesn't tuck under, it arches out. And so it's very common for dancers to have pelvic floor dysfunction. And in fact, when I went to my first specialist appointment at UC San Francisco, their top IC patient was a prima ballerina. Okay. What about CBD to help with managing pain? Hey, man, if CBD works for you, power to you, go for it. We carry several CBD products in our store. Look under pain relief. We just brought in Spectrum CBD Botanicals from Colorado. They also make Colorado Mountain Jams and Jellies. Go for it. Penny says, I had a total hysterectomy in 2009. Now, and understand too, the hysterectomy is quite traumatic to the muscles down there too. Teresa says, I have this, and if I take antibiotics, it goes away. Well, understand that antibiotics also have an anti-inflammatory effect. And so you get a false sense of feeling like the antibiotics are killing something when in fact it might just be making you feel better. But don't believe me. I believe in data. I believe in hard facts. I think it's important to have a next generation urine test. And that will tell you once and for all what is in your bladder at that moment. It will tell you good bacteria, bad bacteria, fungus. And in some cases, depending upon the test that you order, it might even show virus. Mary says, I had 4 exploratory laparotomies with tons of adhesions. Your periods have stopped. Yeah. But I still feel like I have endo. Oh, Marcella says, Marcella, thank you for stars. I appreciate that. I went to the urologist finally after waiting forever. He told me to try pelvic floor and bladder training, but I feel like I have to pee all the time. Frequency is crazy, no pain. I'm just not sure how this will help me. Well, honey, now listen, if your muscles are tight, they're interfering with how nerves normally work. And he explains this beautifully in this book, this Breaking Through Chronic Pelvic Pain book. Basically, let's see. So let me give you an example. Let's say you had a hard fall on your butt and you suffered a compression injury. Bam! All of your weight landed on a 4-inch by 5-inch by 5-inch area on your butt. So 150 pounds, whatever, compress those muscles. Bam! So now we have damaged muscles and weakened muscles. But we also know when you fall, you compress blood vessels. And sometimes blood vessels are damaged, and that's what causes bruising. When you fall and you got a bruise on your butt, that's because you fell so hard, you broke the blood vessels in the area. But what about the nerves? You know, you don't see nerve damage, but nerve damage potentially also happens too. So your nerve fibers have, you know, when you think of a nerve, you're thinking of a tube that goes one way, like there's one nerve in it that goes that way. But nerve fibers sometimes have 2 nerves, one nerve going this way and one nerve going that way. But most importantly, inside the nerve fiber is a little tiny capillary, a blood vessel that supports nerve functioning. A nerve cannot function correctly if it doesn't have active blood supply, because it releases something into your bloodstream and then it pulls it immediately right back out of your bloodstream. And that's how nerves function. And that's how they operate. And so when you fall, bam, you also get a pressurized injury inside the nerve fiber. So now that nerve doesn't have good blood supply and it can't work. And God forbid now you have trigger points. You have muscle knots in your weakened muscles where you fell. Those are long-term compression injuries. And those are also going to immediately interfere with blood flow and immediately irritate nerves. So this is what we know, is that the nerves in the pelvis merge at the spinal cord. and they get shared. In fact, they've done radioactive tracer tracing on the nerves for the bladder and the nerves at the bowel. They do a different radioactive tracer and they follow them and they end up in the same nerve in the spinal cord. So that's when we get something called neural crosstalk. And nerves start influencing each other, and they start causing malfunction. A good example is allodynia. There are moments when nerves beyond the original injury become super sensitive. And that happened to me in my first year with IC, where I went for about a couple of months where even though it was my severe pain was in my bladder, you couldn't touch me anywhere on my pelvis without me crying and really basically screaming. The slightest touch hurt. That's allodynia. And it comes and I mean, it was intense for a couple months and it just went away. As I got better, it got better, right? So eventually those nerves calmed down. But that's an example of how a damaged nerve influences other healthy nerves and makes them dysfunctional. And that is the root of what happens in the somatovisceral reflex, where muscle injury causes nerve injury, which causes other nearby nerves to become dysfunctional, including the nerves in the bladder, giving you frequency urgency. It's called the somatovisceral reflex. Can muscles change organ behavior? The answer is yes. Dysfunctional muscles are going to impair and impede organ processing in the pelvis, just like dysfunctional organs can change muscle behavior, also known as the viscerosomatic reflex. If you've got a screaming bladder because you're going through chemotherapy, your muscles are going to get tight to protect you from that pain. Everything influences each other. And this is where Western medicine fails, because doctors stay in their box. Urologists stay in the urinary tract. Gynecologists stay in the reproductive tract. Gastroenterologists stay in the bowel. And they don't look at relationships. And they don't look at how the muscles influence all of them. And again, this is why this book is so good. I don't care how old you are. You need to get this book. It's free on Kindle. And study it. You're back in college, you're back in high school. You got to learn the structure so that you can direct your medical care. I want you to be able to walk into the doctor's office and say, doc, I have pain on my left side that occasionally shoots down my leg. I think it's my piriformis muscle. Could you please check that for me? And he's going to go, whoa, you know what the piriformis muscle is? Well, yeah, I do. I've done my research. You need to know your muscles. Another interesting tidbit that I think is so interesting. So when I go back, so think about a 7th grader who's fallen and broken her tailbone. She's got frequency urgency. Okay, that was me. Peeing all the time, all night long. I remember Christmas morning, I was getting up every 10 minutes and I was bawling my eyes out. It's ridiculous. And then the first thing that happened after that was I got vulvodynia. Well, which felt like you had a really bad yeast infection that never went away. All right, so here's the vulva. I mean, here's the levator, all right, and look, here's the vulva, right? So here's the urethra, here's the vagina, here's the rectum. So this started screaming for me. And the part that hurt the most was right here, the perineum, this little bundle of tissue between your vagina and your rectum, or for a man, between the base of their testicles and the rectum. This was on fire, like razor blades scraping my skin off, or like somebody sandpapered all the skin off of this area. And I never understood why that was so painful until this book, because what he explains in this book, and you can't see it here, but immediately above, inside the perineum or above the perineum, is something called the perineal body, which is an attachment point for 4 muscles. So no wonder falling on your tailbone, injuring your muscles causes perineal pain because the muscles are literally spasming and pulling up and tweaking this. That's why perineal pain is common. And vulvodynia is common in people who have pelvic floor dysfunction. And again, we have multiple research studies that show that pelvic floor physical therapy is stunningly successful. Stunningly successful. Angie said, just did my bladder installation without a mirror for the very first time. Not sure if I could celebrate that or just cry. Girl, hey man, it's a great skill. I appreciate the skill you have. There's a great skill to have anytime you have tight muscles and or bladder issues is if you ever get to the point where you can't pee for one reason or another, being able to self-catheterize and just get that urine out of there it's cool. And it's very easy to do. I mean, like you're done in 2 minutes. Melanie, at one point when my IC was horrible and I stopped birth control, my IC got a lot better. I don't understand this because I can tell you exactly why that happens, Melanie, because when you're on birth control, it limits estrogen. It keeps your estrogen low. But your bladder needs estrogen to produce mucus. And so we just had a big case study that was just released last year of an 18-year-old woman or a young lady who 2 weeks after starting birth control, bam, I'm waiting for Comcast, so I heard a truck. Bam, there you go. 2 weeks after starting birth control, she got all the symptoms associated with IC, and they got worse and worse and worse and worse and worse over that year. Once she got off birth control, things resolved. So you have to remember that your urinary tract, just like your vagina and your vulva, need estrogen. Angie says, started regular girl a few weeks ago and I'm loving the benefits. Pelvic floor therapy saved my life, according to Mallory. Awesome. My pelvic floor therapy has changed my world with the wand. Oh, and you guys, we got the wand in. We got the wand. Oh, let me check and see. Hold on. I want to make sure we put it back in inventory because I was just up there 2 days ago. Hold on. This is exciting. Let me look here. It's under physical therapy in our store. Where is it? All right. Okay, I know we got 10 in. It's only showing 1. I don't know why they did that. I'm going to up that. I'm going to put 6 in. All right, so let me show you this. All right, so again, okay, Ellen says, I can't sit very long because my hip hurts. Is the hip part of the pelvic floor? Absolutely. Look, girl, look at this. You got to understand this. Here you go. Here are your hips. Look inside. There are your muscles, your pelvic floor muscles. You see that? Attaching directly to your hip bone. If you got a bad hip, that's going to infect your pelvic floor. Piriformis muscles. So the question then is, the other thing I want you to really notice about this model is look at the muscles. They're flat. They're flat. You can see that they are flat and they go up the side of your bones up towards this bone right here, right? But when they're tight, they lift up and they pull. And tight muscles, and so when you start putting the normal structures in here, we put our vagina and our ovaries, and we put our bowel in here, and we put our bladder in here, and then you've all of a sudden got muscles that are lifting up, squeezing. It creates all sorts of issues here. So generally, when you go through pelvic floor physical therapy, what the physical therapist is going to do is they're going to use their finger, and here we go. And for a woman, they go through the vagina. For a man, they go through the rectum. And during that evaluation, they're just going to follow the muscles. They're looking to see, is it lifted? Are there muscle knots? And they're going to be touching all sorts of different muscles. And it's so interesting that they can actually reach over and they can touch your bone, and it does not hurt. Touching your hip bone does not hurt. But that's their job. Their job is to study the health of these muscles. You have 3 layers of muscles. You've got shallow muscles, medium muscles, and deep muscles. Your shallow muscles are here. These are your levators, right? So these are the shallowest muscles of all. There you go. Then above these, we have the mid-level muscles, and then you can see the deep muscles. See, look, there's the deeper muscles right there. So a good physical therapy session involves a physical therapist touching your body. The only way you can access this is through your vagina or rectum, because look, on the other side, you've got some bone. Don't be freaked out by an internal exam or internal therapy. It's the best way to do it. It's the best way to do it. But literally, the most important part of physical therapy isn't necessarily what the physical therapist does. It's what you do when you get home. Because we have to try to recognize what's triggering those tight muscles. Are you going up and down a lot of stairs? Are you riding a bicycle? Or do you have something at home that you're sitting on that's super uncomfortable? So you've got to learn a little bit about cause and effect here and try to figure out in your daily life if there's something that's triggering you. And again, it could be a bad hip, it could be a bad knee, it could be how you walk. A good physical therapist will have you walk down a hallway and back a couple of times. They want to see if you're walking normally, because if you're not, if you've got one leg longer than the other, look at what this does. So let's say you got one leg that's a half an inch longer. So all of a sudden now we have a hip higher and lower that is just not working together. You know, your hips should be fairly balanced. In the end, the other thing you want to do, because this is about self-responsibility, you learning your body. I'm finding it absolutely fascinating, is they will teach you how to use a wand. And this is an example of a wand, because you yourself cannot get your finger very far in there, but a wand works beautifully, especially if you have trigger points. And you can see with a wand how easy it is to follow the length of the muscle. So when I use my wand, let's see, I actually start in the front, and I don't think I can really demonstrate it. I tend to start here, right? I start in the front because I find that the muscles back here are very thick and meaty, where the muscles in front are a little bit more pliant and loose. But anyway, it's just about you learning how your body is. I'm not saying my muscles are normal because I have scoliosis, but you got to learn what your muscles are. And then you've got to learn the early warning sign. For me, it's a pulling sensation. If I feel like there's a hand up my vagina that's trying to pull my guts out of my body, that's a levator spasm. That's when I get out my wand, I lay in my bed, get some KY, and just for 5 or 10 minutes, try to relax it. And it works beautifully. But it's weird. None of us ever thought we would have to do this. You got to be in the right frame of mind, shut the door, do it when nobody else is around, or, before you go to bed, do it under the covers so nobody can see what you're doing. It's amazing how helpful it is. And it's also really interesting how you learn how it changes throughout the day. Like for me, my right side, even though my pain is on my left side, it's my right pelvic floor muscles that get really, really thick and contracted, and I've got to relax that. So Ellen says, I can't sit very long because my hip hurts. Okay. So anytime we have pain with movement, sitting, standing, combined with frequency urgency, we're always going to be looking at muscles. Kathy says, you've helped me so much. Thank you. My doctor hasn't a clue. Angie says, my tight muscles had my colon hostage day. Finally, things got loosened up with dry needling. Right. So sometimes if you have a hard knot, a trigger point, they will use a needle to kind of release it. Your muscles function like this. Normally, your muscle fibers are long and lean, but whenever you tighten muscles, they slide together like this, right? And then when you release, they release. So that's how muscle fibers work. Sometimes they get stuck. They have little tiny pili that attach to the muscle fibers that give you strength. But sometimes a muscle fiber will get stuck like this. We call this a trigger point. And so the way you do a trigger point is you either push on it, and you can push on it and kind of you can go the length of it and just try to get it released. That's one of the things that physical therapists do. Or they can do something called dry needling, which will also help it to release. Amy says, I have scoliosis pain in my hip and knee. Yeah. Yeah, girl. We got the scoliosis club here going on. I keep saying if there's one thing I could change about my entire body, it would be having a straight back. I mean, you can't see that I have scoliosis. Like when I stand up, you can't see it. But if I look, I'll show you. If I bend over, you're going to see that one side of my back is higher than the other. So let me bend over. Can you see that? I don't know. Yeah, it might be hard with my chair. So this side is higher than that side. Anyway, that's an S curve. It was really intense when I was young because I was a fat little girl, not a lot of muscle tone in a family with big boobs. I had a huge growth spurt, 6 inches one year, and my spine just couldn't support it. I had too much weight up here. Lost the weight, became an athlete. Praise God, hallelujah, my curve got better. Patricia says, what happens when you get off of Elmeron because of side effects? What do you take instead? I have an Elmeron transition guide right on our website, right on the front page. Go there and read about that. You would either switch to Elmeron installations, or you would go with a chondroitin-based supplement. Bladder Builder, Bladder Rest, Cysto Protect, Cysto Mend, Cysto Renew. Cysto Protect has a manufacturer's delay for another 6 weeks. Same with Cysto Protect. So Deborah says, knowledge is power. I've never had a doctor talk to me like this. You're better than the doctor. I can't thank you. Well, you should have heard, when I started doing this, I was extremely academic, finger up. Now it's all about peeing and pooping, and I'm very blunt. All right. Lynn says it's still freezing. Angie says it hasn't frozen once on your end. Angie, is this the same? Let's see. All right. So again, on Facebook and YouTube, here, hold on, YouTube. I'm sorry, you guys. Hold on a sec. Let me take a look. Hello, YouTube. I see you guys. Hi, Patty. Patty, have you seen any more freezes, screen freezes? You guys, Facebook, you guys too. What's the quality of the stream? Is my face fuzzy? Is it not clear? We're trying to switch over to Comcast Business. It's going to cost me a lot of money, but I can't do it if it's stopping and starting because my cheaper AT&T never stopped and started. But Comcast might be a clearer a clearer picture, but I can't have it stopping and starting this way. Okay, Patty says it's good quality now. Chinoa says, does the nerves have something to do with me cramping only on my left side, such as my leg and foot, right before my cycle? I also have cramps in my lower abdomen. Absolutely. It's very common for patients with pelvic floor dysfunction to have tight thigh muscles, tight glute muscles, tight, which are in your upper legs, or tight psoas muscles that go up into your back because they all enter the pelvis. They are all influenced by pelvic muscles. But understand too that if you have numbness, if you've got pins and needles, weakness, we always have to look at nerve health. Like right now, because I have 2 ruptured discs in my back, my right leg, my knee is partially numb, and my leg is only at about 80% strength because I lifted too much stuff last fall and hurt my back. Life, right? Sammy says, can you post the links to the Elmeron update? My consultant is arguing with me saying he wants to put me on it, but I've explained about the eye effects and he said he's heard nothing about it and there's no issues. Oh, he's an idiot. He's an idiot. Everybody knows. Even I do believe that when the European Union approved Elmeron last year, they specifically changed the label to talk about pigmentary maculopathy. Just go, if you go to the IC Network website, Sammy, right on the front page is a link to our Elmeron Eye Information Center with links to all the research studies. You can print it all out. I've got a printable sheet that you can print out that's 2 or 3 pages with all of the studies. This is absolutely real. And I don't know what the long-term future for Elmeron is. I would suspect that it's not going to be particularly good. It is still FDA approved, but the US FDA put a giant warning on it last June. Kathy says, using physical therapy and the wand makes life dealable. Excellent. Penny says, any suggestions on the best way to get and take estrogen after many years of not being on it? Penny, I would encourage you to search for topical estrogen safety. Generally, what they will do is recommend a topical cream to use because that is much safer than taking an oral estrogen. When you take an oral estrogen, just like when you take oral Elmeron, it is distributed throughout your body via your bloodstream. I mean, you take it, it's in your stomach, it's dissolving, it's absorbed through the stomach wall into your bloodstream, and then it goes everywhere. And that is, now we know why eye disease is occurring, is they think that the Elmeron is moving all the way up into the blood vessels of the retina, where it is changing the retina and causing pigmentary maculopathy. But the same is true for estrogen. When estrogen is distributed throughout the body, especially to the breasts, it can be linked to estrogen-driven cancers. Whereas topical estrogen and estrogen cream is considered remarkably safe. And so because it stays in the skin, you don't see a lot of systemic absorption with a topical therapy, according to the research studies. But I don't want you to believe me. I want you to go read the research. So Google topical estrogen safety and look at the studies. We get new ones out every year. Mallory says, cycling was my favorite form of exercise. This makes sense why I'm in pain the next day. Yeah, girl. You know, the only way you're going to be able to do it is if you get a specific bike seat that doesn't put any pressure up between your legs. You need to get the 2 round circles. I call it the 2-bun seat, where literally you're just sitting on your glutes and absolutely nothing is touching your crotch. But even then, your glutes are going to take a beating, you know? So Mary says, yes, 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 and all this. I have end-stage bladder disease, and this helps so much. Oh, I'm so glad, hon. You guys, if there's one thing, Mary says, and believe it or not, belly dancing, I can control my abdominal muscles, and you have to relax them to make a good belly dance jiggle. Oh, I love that. I would love to try. I did hula for a while. I like hula. I would like to try that. Except, you know, tall, skinny redhead belly dancing, you got to admit, it'd be pretty funny looking for me. And if you're looking, if you can't find a physical therapist, we have a database on our website, but there's an even better database at pelvicguru.com, pelvicguru.com. Shanoa says, I was told my pelvis is tilted. Okay, that makes sense. So the question is, why is it tilted? Is it tilted because You have scoliosis, or is it tilted? Is it tilted because you have one leg longer than the other? So if you got one leg longer, that's also going to tilt it. That's why a physical therapist should normally measure the length of your legs to see if there's a big issue. Oh, you guys, thank you so much for your stars on Facebook. You guys, if you ever find these meetings helpful, I mean, the way you can give back a little bit, because they are free, right? But, you know, it is work, is you can give me stars on Facebook, or you can come on over to our website and become a member, and you get our wonderful magazine, the Ic Optimist magazine. I think that this is our 18th year. No, we're starting our 19th year of our magazine. And I literally 19 years. This is the most important issue I've ever done, because this is the issue which explains why chronic overlapping pain conditions hurt. Why does somebody end up with IC and IBS and vulvodynia and TMJ and all those stuff? And I realize now doing these, because whenever I'm doing these, I'm actually looking at myself talking, and while I'm doing this, and there are moments when my jaw is slightly off, like, yeah, and that's just because my TMJ is really, really bad right now from all the stress of COVID and stuff. Like, you got to do your TMJ exercises. There's some really good videos on YouTube for TMJ. Try to get these muscles to relax. There was one research study that showed that if you are a teeth clencher, as I am, the odds are you're also a pelvic floor clencher. Okay, let's see here. Now, Facebook, you are saying that the video quality is good. Okay, Amy just asked a question that I think is a really important question. Amy says, will there ever be a cure for IC? And this is, again, where we have to look at subtypes. The word cure implies disease. But guess what? A lot of you don't have disease. A lot of you have injury. You don't cure an injury, you heal an injury. So again, if we go through these subtypes, subtype number 1, Hunner's lesions. Can you cure Hunner's lesions? No, you can treat them, but Hunner's lesions are viral infections, so you would have to use an antiviral. Can you cure chemotherapy-induced IC? The answer is no. You have to create an environment that will support the bladder to heal. Healing is always happening. You can always count on the bladder healing itself. The challenge is we get in the way. That's where drinking coffee every day gets in the way. That's where drinking soda gets in the way. The bladder is the slowest healing organ in the body. It takes 2 weeks for one cell to be replaced. You cannot do something for a day or two and think you're going to get better. Nothing happens in a day or two. You got to be on the diet for like 3 months to really get good healing if you are a bladder wall-driven patient, IC subtype 2. Can you cure estrogen atrophy? No, you're getting older. That's an age-related issue. It's not a disease. Can we heal tight pelvic floor muscles? Yes, we can. These patients are curable with pelvic floor physical therapy. But if there's a bony structure abnormality that's tweaking those muscles, then that's going to be hard, because we got to deal with what's tweaking the muscles, like a bad SI joint. Can we heal pudendal neuralgia? Yes, but we got to figure out where the nerve is being traumatized and release it and calm the nerve down. Can we heal central sensitization, chronic overlapping pain conditions? If we can heal the brain and get the brain out of fight or flight, we can massively improve that. It's called an anterior pelvic tilt. Not sure how it happened. It's good to know that so there's an exercise called a pelvic tilt. I did it this morning, so I'm doing exercises for my ruptured back. So normally when you lay down, you would have a little arch in your back, right? Here, hold on. So when you lay down and your butt's out, you would have a little arch. So with the pelvic tilt, you basically are straightening this out so that your lower back is to the ground. Lots of videos, my friends. Lots of videos. Amy, thank you so much for the 100 stars. I really appreciate it. It helps tremendously, guys. It really does. And I love doing these meetings. I want to do more, but you should see all the phone calls I've got like 10 phone calls I've got to return just from the weekend. And I should be doing that, but we are doing a testing. You guys, also, I do coaching. If you want to spend time, like an hour, talking about your history and all that sort of stuff, you can sign up for coaching on our website. It is, but you can also call us. And if I'm available, I'd be happy to talk to you, no charge. But if those are like 5 or 10 minute phone calls. But if you want to spend a good long time, really go over your history, prep for a doctor's appointment, questions, things like that, you would sign up for coaching. Genoa says, yes, my arch is deep and hurts when I lay down. Interesting. So you're really going to be working with a physical therapist and your doctor to try to resolve that. And if it hurts, obviously the rule is don't do it. So you're going to have to really listen to your physical therapist because this is your back. You can't guess. You got to work with an expert so you don't hurt yourself. All right. All right, my friends. Well, listen, I am waiting. Hi, Donna. I'm sorry, I didn't see you there. Well, I did see you there. Hi, Donna. Love you, love you, love you. All right, my friends. Well, this has gone longer than I expected. But right now, y'all are saying that the stream is looking pretty good. So they've been working on it. They should be here any minute. So we'll see. So it looks like the last time we froze was at 2:12 on YouTube. Thank you for writing that down. And it looks like that happened on Facebook too, but it's a bit better now. So how about the screen quality? I mean, is it fuzzy or do you have a clean, clear picture of me? Shannon says, my uterus is tilted and my coccyx always hurt, but you think that can cause... Girl, hey man, Shannon, seriously, you have to get this book. Where is it? You have to get this book. If your tailbone always hurts, that's a huge, huge, huge sign. So let's look at the tailbone for a moment. Dr. Weiss in that book was the first one to really tell us to start asking about tailbone injuries, seeing lots and lots of tailbone injuries. And so let's look at the tailbone for a moment, right? So I don't know if you can see this. So look, here's your tail. We have tails, and some babies are actually born with long tails and they actually remove them. But your tail, see, this is where being on the screen is hard because if I hold my finger the wrong way, it'll be mirrored in the wrong way. I mean, it's weird. You can see that it flows inward. Think about a dog. When a dog is waving its tail, it's the muscles are relaxed, the tail is up, wag, 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 and this tail would be pointing this way. But think about a dog under stress. That tail is deep between his legs or her legs, and those pelvic floor muscles are pulling it down. So you can see how the tailbone is going to be influenced by bad muscle behavior and or how the tailbone itself can cause muscle dysfunction. I shared one patient story in our magazine last year, and it was fascinating. So, and it really is resonating now. I mean, now we understand the whole tailbone connection. So it was a patient who attended one of these meetings. And I always say, you are an anatomical mystery to be solved, right? We have to study your anatomy. We cannot make good discussions about therapies until we understand the basics of your anatomy. And so she had been diagnosed with IC. And I went through the subtyping and I talked about muscles and I talked about nerves and how when you have pudendal neuralgia, you often have pain when you sit down that is improved by standing. Or you might have pain shooting down a leg like sciatica, or you might have persistent genital arousal disorder, or just something as simple as pins and needles along your vulva or by your rectum, right? So she read up about that. And then she went to her doctor and she said, I think I have pudendal neuralgia. Here are my symptoms. And the doctor went, oh, I think you might. Based upon what you're describing to me, yeah, you really could have pudendal neuralgia. So he ordered some basic x-rays. And what did they find? They found that her tailbone, instead of being curved inward, was straight out. It was straight out and it was crooked. So instead of it being like this, her tailbone was like this and it was bent to the side, which is something we see. We're seeing that more. And so imagine what having a tailbone out of position would do to these muscles, right? So now we've got the muscles that are pulling upwards. They're being stretched farther than they're meant to be. And then one side is stretched even farther because it's at an angle instead of being straight. So she went to a variety of doctors, and they all confirmed, yeah, man, your tailbone is messed up bad. So although I am not a fan of chiropractic at all, because I have one very, very dear friend who had a broken back from chiropractic, from a drop table, and he's slowly recovering. Um, that's what she did. She started making weekly appointments with a chiropractor who worked on her muscles and her bony structures. And by the end of that year, her pain went down like 90%. She wasn't flaring. Her bladder felt better. And y'all know what else happened? She got pregnant and had a baby and everything went fine. Where before that, they were all thinking bladder, 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 bladder. No bladder therapies helped her. And now we know why. It was a tailbone injury that was affecting her pelvic floor. When they got the tailbone into the correct position, her symptoms improved, her muscle health improved, and life is happy for her now, where before she was really thinking very dark thoughts. And so you really are an anatomical mystery to be solved. We have got to study your pelvis to figure out what the hell is going on. Don't assume it's always your bladder. And I started the meeting with this book. This is the book that will help you figure out if it's fibroid tumors, endometriosis, tailbone injuries, hip issues, rheumatological issues, blood flow issues. This book is the bomb. It just came out, Harvard Medical School, features the best in the world. I was very honored when they invited me to contribute a chapter. So I got published by Harvard. It's like so freaking cool. I mean, we already won one award from Harvard for our website, but this is awesome. And it's free. It's free on Kindle Unlimited. No excuses here. If you're not getting better on bladder therapies, for God's sake, download the book on Kindle Unlimited and just scroll through it and go, gee, I wonder, could this be me? What type of bone and ligament issues can lead to a pelvic fracture? And look, here's a great picture of the ligaments, right? So if you sustained an injury, if you rear-ended another car and your legs would straight, all those forces would be directed right up into your muscles and ligaments in your pelvis. It talks about skin irritation, talks about all sorts of stuff. So this might help you solve the mystery of your pelvic pain. And if you are a muscle patient in particular, or you've sustained pelvic trauma, this is the book to get. Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. And it, again, is free on Kindle Unlimited. No excuses. Listen, you got, what do you have to lose? Pain. To make an effort, read about it. You might be surprised by what you find. And let me, hold on a sec. He talks about how to shop for cars. You know, I mean, it's a love letter to patients. It's such a good book. Breaking Through Chronic Pelvic Pain, Jerome Weiss. Completely changing how I'm working with patients. It's so good. And look, he talks about double crush syndrome, which spreads the pain around. So remember we talked about compression injuries, and the question was, you know, how would a compression injury affect the bladder? Let me read this. This is called double crush syndrome. I frequently see patients with symptoms related to one branch of the pudendal nerve, such as sit bone pain, who go on to develop symptoms related to another branch of the nerve, such as rectal pain. This is because when movement in the nerve trunk is restricted, the tension and movement in all of its branches are likewise altered. In the field of neurophysiology, the spread of symptoms is referred to as double crush syndrome. Here's a typical scenario. When the pudendal nerve is compressed in the narrow space between the ligaments, the nerve's normal sliding motion becomes restricted. The friction a 1-inch nerve segment would normally undergo when it slides back and forth between the ligaments is then concentrated onto a 1/4-inch segment that is unable to slide beyond the clamp. Okay. So interesting. Anyway, it goes on. See, look at this picture. Okay, normal nerve, round, cylindrical, crush nerve, compressed nerve. Look at what that does. Isn't that interesting? I wanted to read a success story to you, though. Hold on, hold on. Okay, this is it. This is interesting. This is very, very interesting. So, Dr. Weiss, in his practice, when he saw bladder therapies weren't working for a lot of people, he dove into muscles and nerves, right? And his entire practice became a myofascial practice. And he learned a lot from a doctor named Dr. Janet Travell, Travell, who was the White House physician to President John Kennedy, as well as President Johnson. And she was a master at myofascial and trigger point therapy. I have a book by her myself. So anyway, let me just read this section on John F. Kennedy because I think you'll find it fascinating. On May 26, 1955, Dr. Travell had her first appointment with Senator John Kennedy at her office in New York City. Her recollection of that day, as recorded in her autobiography, were as follows, quote, "At our first meeting, this thin young senator on crutches could barely navigate the few steps down from the sidewalk into my ground floor office. Left-sided pain in his back and leg made it almost impossible for him to bear weight on that foot, and a stiff right knee made it difficult for him to step up or down with his weight on his right leg because that required bending the right knee." To put it bluntly, John F. Kennedy, U.S. Senator from the Commonwealth of Massachusetts, 3 days shy of his 38th birthday, was a physical wreck. His medical history was a nightmare. It included numerous hospitalization as a child, a diagnosis of colitis, football injuries that initiated his back problems, and a serious back injury during World War II, after which he was diagnosed with Addison's disease. Addison's disease is a rare endocrine disorder wherein the adrenal glands produce insufficient steroids, and if left untreated, can be fatal. So in October 1954, 7 months before his first visit with Dr. Travell, Kennedy had a fusion in his back that was a disaster. Shortly after the procedure, a serious infection occurred and another surgery was performed to remove the plates and the 3 screws that were holding his fused discs together. Kennedy then went into a coma and came so close to death that he was actually given last rites from the Catholic Church. During a 2.5-year period from 1955 to 1957, Kennedy was hospitalized 9 times for a total of 45 days. Now, fast forward 5.5 years to May 1955, when John Kennedy met Travell for the first time. to 1961. It was a very cold, snowy, but sunny day in Washington, D.C. When at exactly noon, he took the oath of office to become the 35th president of the United States. The question is, how, within a relatively short period of time, did this basket case of a man who couldn't even go downstairs without help, who walked with crutches or stand without pain, end up in the Oval Office? Two important events happened at the same time that changed his life. First, the drug cortisone became available to treat his Addison's disease, improving his life expectancy. And then Janet Travell became his daughter. It was Dr. Travell's ongoing treatment of his incapacitating back problems that made it possible for him to withstand the rigors of the presidential campaign and bear up under the stresses of office. She's a genius, is how President Kennedy described Dr. Travell for curing the ailments that troubled him. Now, it was Dr. Travell who was the one who made the connection between the foot and pelvic pain and Morton's toe, that if you don't walk normally, your pelvic floor is going to be impacted. And so it says, in her autobiography, Dr. Travell states how she was aware early in her career that when the second metatarsal bone was longer than the first metatarsal, it could transmit abnormal mechanical stress to the ankle, knee, hip joints. It could in turn produce pain. Anyway, and that's why we now look at the feet. That's the missing link for a lot of patients. There are some patients whose muscles are always tight, and we have to figure out why. What bony structures are putting stress on those feet, on the pelvis? And it could be a hip, it can be an SI joint, it could be a knee, but for many of you, it's a foot and even a toe known as Morton's toe. All right, my friends. Well, there you go. You had a nice little drop-in support group meeting. Lisa says, I have pudendal neuropathy with 4 blocks, 2 with radio frequency ablation. It's some better, like in sclerosis, tight muscles. Haven't been to therapy yet. I burn 24/7 inside. I have IC. My doctors want me to get the cystoscope. You're using clobetasol for lichen sclerosis and pain management. You're doing Cymbalta to calm nerves down. You're doing throat coat tea and overactive bladder meds. So girl, you are an anatomical mystery to be solved here. You've got pudendal neuralgia. That means that something is impacting a nerve. Normally it's muscle. So now we got to go to the muscles and figure out what the hell is going on with your muscles. And I'm really surprised that you haven't been to physical therapy yet, because that's the connecting piece here. Because if those muscles are tight and dysfunctional, that's going to mess with everything. That could give you vulvodynia. That could irritate your nerves. They could contribute to lichen sclerosis, all of those things. So it's going to be very, very fascinating to see what a proper pelvic floor assessment finds in your pelvis, hon. Pamela says, I have one hip higher than the other. Nobody looked at the feet before. Well, that means you probably have one leg longer than the other. And read the chapter on the feet in the book. It's mind-blowing. All right, my friends, I'm going to call it here. We've been doing this for 2 hours and 15 minutes, and I've got a patient coach I've got to do. So I will talk to you later. If you like these meetings, make sure you like our Facebook page, subscribe to our Facebook page, come on over to YouTube, subscribe to YouTube. You guys on Facebook, please come on over to YouTube and subscribe to that channel. The more subscribers we have, the more I will be able to do other things. I got to start bringing in guest speakers. I've got several guest speakers that are ready to come on. We just have to make the technology work. And here's Comcast. So I'm going to, here. Hi, this is Jill. All right, you guys, I'll see you later. Hello? Yeah. Is this Comcast? Yeah.